Good afternoon. I'm Christine Edmonds. Thank you so much for having me today. I'm looking forward to speaking with you about supplemental breast imaging to improve screening in women with dense breasts. The objectives are to define mammographic breast density, discuss the clinical implications, go over the current strategies for supplementally screening women with dense breasts, and finally touch on future direction. So when we say mammographic breast density, what we are talking about is the amount or proportion of fibroglandular tissue relative to the amount of fatty tissue. Fibroglandular tissue means the breast glands and ducts, and that's the tissue that is the origin of nearly all breast cancers across subtypes. To date, this amount of tissue or density is visually assessed just with a gestalt assessment by the radiologist, focusing on the potential of that dense tissue to mask breast cancers. Per the American College of Radiology, it is broken into 4 categories from A, with the least amount of that fibroglandular tissue, fatty category, through B, which is scattered, C, heterogeneously dense, and D, extremely dense. So today when I say dense tissue, I'm binning group C and D to include heterogeneously dense and extremely dense tissue. This is what it translates to on mammography. So you can see the dark gray here, that is fat, in contrast to the very bright white appearance of fibroglandular tissue. That's the tissue with cancer, which cancers arise from. And of note, cancers also typically appear bright white. Thus, you can understand why dense tissue could potentially mask breast cancers on mammography. Here's what the 4 categories of density look like on mammogram from A, fatty, to D, extremely dense, which has the most of that dense white fibroglandular tissue. You can also see the breakdown across studies around the United States of the assessments by radiologists. 10% fatty, 10% get extreme. The 2 middle categories each receive 40%. Thus, when you think about who needs supplemental screening, it's actually quite a lot of women, as close to 50% fall into those dense categories. So what impacts breast density? Of course, genetics, it's how we're born. Endogenous hormones, so age and menopause. Traditionally, breast density gradually declines following menopause. Likewise, dense tissue increases during pregnancy and lactation. Also, exogenous hormones impact it, with hormone replacement therapy increasing breast density, while anti-estrogen therapies such as tamoxifen decrease it. So why does this matter? What are the implications of having dense breast tissue? Well, for one, it decreases sensitivity of mammography. I already touched on masking. So having more of that dense white tissue, that fibroglandular tissue, does notably decrease the sensitivity of screening mammography. Likewise, there's larger tumor size and related worse prognoses at diagnosis among women with dense breasts. You can see how that translates clinically. So A through D, from fatty to extremely dense breasts, with the ultrasound images showing small cancers below them. So A, it is easy to see the tiny cancer in this otherwise fatty breast, this little white mass here. It becomes increasingly difficult to see the cancer here in the scattered breast. In C and D, heterogeneous and extremely dense. Likewise, the cancer could not be visualized at all. You can see the small invasive cancers that were found at screening ultrasound. For those of you who are familiar with digital breast tomosynthesis, you might be wondering how this comes into play with screening. Digital breast tomosynthesis, or DBT, is low-dose images that are acquired over an X-ray arc, and it allows us to have a 3D reconstruction so that we can actually scroll through areas of dense tissue. The FDA approved it in 2011, and it now represents the standard for mammography, both screening and diagnostic. It can mitigate some of the masking of cancers due to that 3D reconstruction. Notably, studies to date show reductions in screening recall rates. That means we have to recall fewer women from their screening mammograms to evaluate abnormalities that simply turn out to be areas of dense tissue. There's also a little bit of an increased cancer detection rate. Tomosynthesis helps us find 1 to 3 additional cancers over the standard 4 to 6 cancers per 1,000 found with screening mammography. Unfortunately, though, it remains unclear what the impact on cancer detection rate is in women with dense breasts from tomosynthesis, particularly among women with extremely dense breasts. So aside from masking and decreased sensitivity, the other implication is increased cancer risk. Women with extremely dense breasts have twice the risk of average density and 4 to 6 times the risk of women who have fatty breasts. We know also that it increases the risk of all breast cancer subtypes, and dense tissue is associated with increased risk of invasive disease and larger tumor size at diagnosis. And of course, these are associated with worse mortality, worse prognoses. So back to supplemental screening. Knowing all of this about density, who might need supplemental screening, and how should we do it? Well, up until recently, it was up to state laws. Most of the states had state laws requiring institutions to notify women if they had dense breasts. But now, as of recently, the FDA is mandating this. And so 18 months in the future, all institutions around the country will have to let women know if they have dense breasts. They'll also have to indicate to them that this could mean decreased sensitivity of mammography, and also increased future risk of breast cancer. However, it does not spell out exactly what patients should be doing for supplemental screening, and if in fact they even definitely need it. So what are the options to date? Well, the most utilized one is ultrasound, either traditional handheld ultrasound or newer automated breast ultrasound. Contrast enhanced breast MRI, either standard or abbreviated protocol, is becoming increasingly utilized for screening around the country, while contrast enhanced digital mammography is quite new and still undergoing studies to see how it may play in screening. Per the American College of Radiology, all three may be appropriate in women with average risk and dense breasts for supplemental screening, but it does not really define what is the preferred option. So let's go through these briefly. Screening breast ultrasound, again, the most utilized currently. It does find a few extra cancers per 1,000 in women with dense breasts. The majority of those are invasive cancers, so the ones that we really want to be finding clinically. However, it comes at some drawbacks. So notably, it really increases the rate of recall from screening, meaning the number of women that need more imaging. It also increases rates of women who need follow-up imaging, and it results in a whole lot more biopsies and decreases the positive predictive value of those biopsies. It's quite time and labor intensive. It can take 15 to 30 minutes simply for the scan, much less the interpretation time, and there's great user variability. Here's an example of screening breast ultrasound and how it is applied in clinical practice. So on the left is a mammogram, 65-year-old female for screening. She has heterogeneously dense breasts. That mammogram was interpreted as negative. However, she underwent screening ultrasound, in this case, the automated breast ultrasound, which is one type, and it identified a very small mass sitting in her dense tissue. On subsequent diagnostic ultrasound images seen in below, you can see that that suspicious mass with irregular margins persists. This was biopsied and yielded a small or stage 1 mixed invasive ductal and lobular cancer. On to MRI. So this represents the gold standard for screening, and that is because it has extremely high sensitivity and thus very high cancer detection rates compared to all other breast imaging modalities. Likewise, its performance is not affected by breast density. On the left, you can see that this woman has extremely dense breasts. The white is her dense breast tissue sitting in the gray fat. This is with contrast, and the tissue is subtracted. So all you see is enhancement, and you can see why it would be very easy to identify an enhancing cancer. The cons of MRI: high false positives leading to unnecessary biopsies, high cost, limited reimbursement, especially in women who only have dense breasts but otherwise no risk factors for breast cancer, long acquisition times, and claustrophobia, which leads women not to want to get MRI even when it is indicated. This has led to the abbreviated MRI to try to circumvent some of these issues. It's much shorter. Therefore, it comes at lower cost and is more tolerable to patients. However, it fortunately maintains the high sensitivity of MRI. So here's an example of abbreviated MRI, or that shorter protocol for screening. This patient's first 2 screens were negative. You can see then in 2021, she has about a 5 millimeter enhancing mass in her left breast. That was deemed suspicious. Of note, she had just had her annual screening mammogram 1 month prior. She is extremely dense, and this cancer was therefore masked or not apparent. So it picked up a stage 1 invasive ductal carcinoma. Finally, I will quickly touch on contrast enhanced digital mammography, or CEDM. It involves intravenous contrast followed by a 2-minute wait period, and then we obtain routine mammographic views at 2 energies to allow us to see the regular mammogram plus enhancement. However, there is limited data to date on this application for screening, as most of the studies are in women for diagnostic purposes, such as those women with lumps or those who have been recalled for screening. However, limited data does show similar to slightly lower sensitivity than MRI. It's lower cost and shorter exam time, and early data shows it's preferred by patients over MRI. This is what this looks like in practice. So this patient has a cancer. These right 2 images are contrast. You can see that with contrast, this cancer avidly enhances, is very easy to detect, although on the left, without contrast, it's somewhat masked by the dense tissue. So in summary, ultrasound is affordable and accessible, but limited sensitivity and high false positives. MRI, excellent sensitivity, but costly, limited access and poor patient adherence. Contrast mammography has high sensitivity and is preferred over MRI, but it is still exploratory. What is up and coming? Well, hopefully automated mammographic textural analysis will also really help us here, as it has been incorporated into risk models and adds good information on who needs supplemental screening beside density. Novel imaging-based biomarkers, particularly for MRI, are coming down the pike, as are novel blood-based biomarkers to predict exactly who is at risk. And lastly, artificial intelligence will likely be a key player here, as deep learning models for predicting risk based on imaging, including texture features, are already very promising. Studies of these deep learning algorithms compared to the traditional breast cancer risk models like Tyrer-Cuzick show that image-based deep learning models, especially those models that can also incorporate traditional risk factors, substantially improve risk assessment over 5 years. So we still need novel approaches to precisely define who, among all those many women with dense breasts, actually need supplemental screening. How should we screen them and when we should screen them? And as we continue these investigations, we must be extra careful to consider the impacts of cost, access, and study populations on health equity and the health disparities, as we don't want to increase these more than they already are as we develop the imaging modalities and the plans for utilization. Thank you.